This presentation is on Eczema, Atopic Dermatitis by Meredith Love, ECPI University. Pathophysiology of eczema. It is a chronic skin disorder with intracellular edema and epidermal breakdown. The cause is multifactorial and includes genetic predisposition, altered skin barrier function due to filaggrin gene mutations and filaggrin deficiency, reduced ceramide levels, decreased antimicrobial peptides, altered innate immunity, altered immune responses to allergens, irritants, and microbes. Physical assessment findings are lesions are red, scaly, edematous with indistinct borders. During childhood, lesions are found on the scalp, face, trunk, and extensor areas of the extremities. During adolescence and adulthood, lesions are located on the head, neck, flexure areas. Common diagnostic findings. There's no specific diagnostic testing for a definitive diagnosis of eczema. However, many individuals with eczema do have elevated levels of serum immunoglobulin E, interleukin-4, eosinophils, and have a positive skin allergy test to common allergens. The clinical presentation of eczema is that the skin is dry, itchy, sensitive, and easily irritated. Lesions are erythematous, scaly, rough, and thick. Scratching can cause excoriation and cause infection and crust formation. It's most common in children with exacerbation throughout life, and the person usually has a history of allergies. Treatment of eczema: topical corticosteroids, topical immunomodulators, oral corticosteroids, antipruritic agents, and emollients. Topical corticosteroids, the mechanism is they prevent the movement of macrophages and leukocytes by reversing vascular dilation and permeability in the area, which in turn decreases erythema, edema, and pruritus. Implications for use: dermatitis, psoriasis, lichen planus, discoid lupus erythematous. Rational drug selection: you use a low potency for children, and if you're going to use it on the face, and use a higher potency if they are crusted lesions. Ointments are best for treating eczema because they are occlusive, and eczema lesions are dry and scaly, so it locks in the moisture. Side effects: localized skin irritation, skin atrophy, striae, hypopigmentation, and hyperglycemia. Patient safety considerations: patients should be educated to not put the medication near the eyes and always use it exactly as it is prescribed. Considerations: should not be used in children long term due to the interference with growth and development, and also should be avoided during pregnancy. Topical immunomodulators. The mechanism is it inhibits calcineurin and decreases inflammation. Implications for use: non-steroidal treatment of atopic dermatitis when it has not been responsive to other therapies. Rational drug selection: pimecrolimus for mild to moderate atopic dermatitis, and tacrolimus for moderate to severe atopic dermatitis. Side effects: burning, pruritus, tingling at the application site, and systematically it can cause headache, fever, and flu-like symptoms. Patient safety considerations: should not be applied to site with an active cutaneous viral infection, malignancy, or pre-malignant skin conditions. Also should not be used in pregnancy or breastfeeding mothers and for children under 2 years old. Oral corticosteroids mechanism is it suppresses the movement of polymorphonuclear leukocytes and reverses increased capillary permeability, which in turn decreases itching, edema, and redness of the skin. Implications for use: severe dermatitis, asthma, COPD, angioedema, urticaria. Rational drug selection: prednisone is used in children and it is used for a duration of 2 to 3 weeks. Methylprednisolone is used over 6 days and it is a pre-measured dose pack. Side effects: increased appetite, headache, restlessness. Patient safety considerations: it should not be taken long term because it will have damaging effects, and it also should be avoided in pregnancy because it can cause birth defects. In patients with diabetes, oral corticosteroids you might have difficulty with glucose control. Antipyretic agents, mechanism of action: it blocks H1 and H2 receptors and decreases the development of edema, irritation, and pruritus. Indications: itching and moderate to severe pruritus with atopic dermatitis. Rational drug selection is based on severity. Topical Benadryl for milder cases and doxepin for severe cases. Side effects: skin irritation. If used for an extended period, it may cause drowsiness. Skin irritation is for the topical agents. And patient safety considerations: should not be used with MOIs, alcohol, and cimetidine. Avoid using for more than 1 week. Emollients, mechanism of action: creates an occlusive barrier and confines moisture in the skin. Indications: treat or prevent dry skin. Rational drug selection: it can become costly because you have to buy a lot and all the time. Generic equivalents are good to use, or white petroleum can be used to cut down the cost. There are no side effects. And patient safety considerations: patients need to apply directly after a bath for the best results. Avoid getting them in the eyes and avoid emollients with lanolin if you're allergic to wool. Patient education for eczema. Eczema is a chronic condition with cycles of dry skin and exacerbations. Patients need to be taught that skin hydration and avoiding the triggers are the keys to reduce symptoms and flare-ups. And possible triggers that are avoidable are harsh soaps, detergents, wool, synthetic fiber, stress or anxiety, cold or dry environments, and certain foods may cause eczema to be flared up, and the patient needs to identify them and avoid them. Patient education, again, interventions for adequate skin hydration. The patient needs to be taught to take short baths or showers with lukewarm water and to use minimum soap that is mild and unscented. And it needs to be, emollients need to be used immediately after drying off from a shower or bath. When there's exacerbation of eczema, the patient needs to seek medical help from their healthcare provider, and also avoid scratching the skin because it can worsen the symptoms and it can also lead to an infection of the skin. Again, patient education on all the medications that can be used for eczema. Topical corticosteroids, they're given as the first line therapy for mild to moderate eczema. Improvements should be seen in 2 to 3 days, and complete healing should be achieved in 2 to 3 weeks. The patient does need to make a follow-up appointment if they do not see any improvement after 2 to 3 weeks. And It has also been proven that the use of topical corticosteroids used intermittently in stable eczema can reduce exacerbations. The topical immunomodulators are given for mild to moderate eczema as a second-line treatment if the topical corticosteroids are not therapeutic. When using immunomodulators, patients need to be educated to not occlude the area, leave the area open to dry or open to air, and it may take 2 to 3 weeks to see an improvement. And this is a long-term therapy, so the patient needs to know that they will need to go back to the doctor every 6 weeks when on these medications. Antipyretic agents such as Benadryl can be used for the itching. Benadryl is sedating, so it's best that the patient just take it at nighttime. It can also help with unconscious scratching when they're asleep. Benadryl is not expensive. It can be found for $1 at some stores. Zyrtec can be used during the day for the itching because it is less sedating. Emollients, patients need to be educated that they don't need a prescription for these. These are just over-the-counter lotions and creams. Examples, Lubriderm, Eucerin. Eucerin patients don't need to use them if they're sensitive to lanolin. Another example, Aveeno and generics can be used of any of these, and they will cut down the cost if they're generic. White petroleum is the least expensive. So if the patient has financial difficulties, they can use white petroleum as well. A large amount of emollients will need to be consistently bought and used. The patient needs to know that it's not short-term, it is long-term. Infections can occur with eczema, and the patient needs to be educated on the signs and symptoms. They are pus, pain, increased swelling, redness, warmth to the area. Increased itching has also been found to be linked to infection. So if you have any of these symptoms, the patient needs to notify the provider. And things to do to ensure adherence to the therapy is to educate the patient at every visit about the importance of continued emollient use and to avoid the triggers. Also, providers need to assess barriers to proper disease management and assess socioeconomic factors like health insurance coverage and the ability to avoid the triggers. And also to ensure therapy adherence, provide alternatives such as less expensive medications. Important points for a management plan. Cultural practices involving illness, medication, and bathing should be assessed, and the management plan should tailor to these preferences. And eczema may affect psychosocial health, so it's important for providers to assess for depression and anxiety. And it would be helpful to provide resources for eczema support groups and other tools to aid in the management of this condition. Evidence-based treatment for eczema. One study is called Use of Topical Corticosteroids in Dermatology, an evidence-based approach by Das and Panda, published in 2017 in the Indian Journal of Dermatology. It is a systematic review of scientific literature on the various indications of topical corticosteroids. The findings of the study are that the use of topical corticosteroids 2 times per week in stable eczema profoundly reduced the occurrence of exacerbations. Another evidence-based treatment, Atopic Eczema Research and Update by Lawton. It was published in 2018 in the British Journal of Nursing. It is a systematic review of all evidence-based research studies conducted on eczema up until 2018. It summarizes all the old and the new literature in the areas of prevention, treatment, management, and eczema involving newborns. There are multiple findings in this review. One that supports my management plan is that emollients should be the foundation of managing eczema. The article states that emollients should be used in mild, moderate, severe eczema and when the skin is clear of eczema. It should be used all the time. Some supporting evidence of the patient management plan that I have. One article, Coping Strategies and Quality of Life Among Patients with Chronic Psoriasis and Eczema. It was published in the Indian Journal of Dermatology, Venereology, and Leprology in 2017. And this study assessed coping mechanism and quality of life of patients with either psoriasis or eczema. The study used the Medical Coping Modes Questionnaire and the Dermatology Life Quality Index Questionnaire. The findings of the study were that eczema patients had a greater impairment of quality of life when the severity of their disease was high. The study concluded that providers need to address mental health with these patients and that psychological interventions are equally important as interventions in the treatment of eczema. Another article is called Itching and its Related Factors and Subtypes of Eczema, a cross-sectional multi-center study of hospitals of China. It is a cross-sectional multi-center study published in Scientific Reports in 2018. It examined the link between itching and eczema in 8,758 patients. And the study found that increased itching is associated with suspected bacterial infection. So these findings suggest that an increased severity of itching with eczema could be indicative of a bacterial infection. The bacterial infection needs pharmacological intervention, so the patient would need to see a doctor if they have increased severity of their itching. Another study is the Elimination Diets in Eczema, a Cautionary Tale by Young. It was published in 2016 in the Journal of Allergy and Clinical Immunology. Young conducted a systematic review of all research studies and examined the link between food allergies and eczema. The article concluded that literature reporting improvement of eczema after eliminating certain foods is current and old as it dates to the early 1900s. So improvement of eczema can be achieved with eliminating certain foods. And here are my references.